بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. I am Dr. Muhammad Shigiddi. It's a pleasure to be here today to discuss disorders of potassium homeostasis, a topic that is both fundamental and critically important in everyday clinical practice. Before we begin, I would like to extend my sincere gratitude to SAMA for organizing this session and for their continuous effort in supporting medical education and professional development. Starting with hypokalemia, which is defined as a serum potassium level of less than 3.5. So the patient presents with symptoms which can vary according to the degree of hypokalemia, although it's not 100% correlation. For example, in mild cases, patients can present with muscle weakness or cramps and fatigability, and in severe cases, patients can develop arrhythmias or even paralysis. Regarding the causes of hypokalemia, we have three major groups or mechanisms: shifting of potassium from extracellular space to intracellular space, gastrointestinal loss of potassium, or increased renal potassium loss. Shifting of potassium. As we know, potassium is primarily an intracellular cation with 98% of total body potassium located inside the cells, mainly muscle cells, RBCs, and the liver, and only 2% is found in the extracellular fluid. So hypokalemia can occur when a lot of potassium is shifted from the extracellular space to intracellular space, leading to low serum potassium level. Sodium-potassium ATPase moves sodium out of the cell and moves potassium into the cell. So if this pump is overstimulated, this means more potassium will be moving from the extracellular space to intracellular space, resulting in hypokalemia. So the causes of overstimulation of this pump can be due to drugs like insulin, beta-2 agonists, salbutamol and albuterol, and other sympathomimetics. Apart from drugs, in alkalotic states, the hydrogen potassium pump is inhibited. This pump normally moves potassium out of the cell and hydrogen into the cell. So if it's inhibited, like in alkalotic states, this means less potassium will be moving from the intracellular space to extracellular space, thereby decreasing the extracellular potassium and resulting in hypokalemia. Coming to gastrointestinal loss of potassium, we lose potassium via the GIT tract either by vomiting or by diarrhea. Vomiting will lead to loss of potassium and hydrochloric acid, leading to hypokalemia and metabolic alkalosis secondary to loss of potassium and protons, while diarrhea will lead to loss of potassium and bicarbonate due to decreased intestinal absorption, leading to hypokalemia and metabolic acidosis. The third cause of hypokalemia is renal loss of potassium. We have four causes of increased renal loss of potassium: either problem with tubular reabsorption of potassium, increased sodium delivery to the distal tubules, hypomagnesemia, and hyperaldosteronism. So potassium is mainly absorbed in the proximal tubules as well as the distal tubules. And if potassium reabsorption is decreased due to any reason, it will lead to increased potassium loss in the urine and hypokalemia. While sodium reabsorption occurs mainly in the lobe of Henle in the ascending limb as well as in the distal tubules. Sodium reabsorption is blocked at the level of the thick ascending limb of Henle or at the level of the early distal tubules. This will increase the sodium delivery to the distal nephron. This stimulates, if a lot of sodium reaches the distal nephron, this will stimulate sodium reabsorption in exchange of potassium in order to decrease the positive charge. So we will absorb more sodium and you will secrete more potassium in the urine, resulting in hypokalemia. And that is how the increased sodium delivery to the distal tubules promotes hypokalemia. And as we said, low magnesium states and hyperaldosteronism both can lead to increased potassium loss. First cause of increased renal potassium loss is renal tubular acidosis. There are many types of renal tubular acidosis, but the types that are associated with hypokalemia are type 1 and type 2. Type 1 renal tubular acidosis affects the distal part of the nephron, and type 2 affects the proximal part of the nephron. So we will start with type 2, which is the proximal renal tubular dysfunction. It occurs due to many causes, but eventually it will lead to defective reabsorption of potassium and bicarbonate. So this can cause increased excretion of both bicarbonate and potassium, resulting in hypokalemia and metabolic acidosis. Generally, the distal tubules are responsible for hydrogen secretion, and in proximal renal tubular acidosis, the distal tubules are totally intact. So the hydrogen secretion will be maintained, and the urinary pH will still be acidic. The normal urine pH is between 4.5 to 8, and the average urinary pH is 6. We say that the urine is on the acidic side if the urinary pH is less than 6 or 5.5, and on the alkaline side if it's more than 6 or 6.5. So it's an important feature that in the proximal renal tubular acidosis, the urinary pH will be less than 5.5, and the patient does not lose the capacity to acidify his urine. And this is an important feature to differentiate between type 1 and type 2 renal tubular acidosis. In distal RTA or type 1 RTA, the defect here in the distal tubules. The distal tubules normally secretes proton into the urine and reabsorbs potassium. So if we have a defect here, this means we cannot reabsorb potassium, and at the same time we cannot excrete hydrogen ions. This will result in building up of hydrogen as well as excreting more potassium, resulting in hypokalemia and metabolic acidosis. And here the affected part of the nephron is the distal tubules. So here the patient loses the capacity to acidify the urine, and here we will find the urinary pH usually more than 5.5, and the urine might be on the alkaline side. The second cause of increased renal potassium wasting is increased distal sodium delivery. So either a defect in the thick ascending limb of Henle or in the early distal convoluted tubules, in the which are the main sites of sodium reabsorption. If the sodium reabsorption is blocked at either the thick ascending limb of Henle or the early distal tubules, this will increase the sodium delivery to the distal nephron, and this can stimulate the aldosterone to increase the reabsorption of sodium through the epithelial sodium channels, and this will increase the positive intracellular charge, and the excess charge will be removed to the urine in the form of hydrogen and potassium ions. So the end result, the patient will develop hypokalemia and metabolic alkalosis. So blocking of the sodium reabsorption in the thick ascending limb of Henle, example of the blocking agents is loop diuretics, and in the early distal convoluted tubules, the thiazide diuretics blocks the sodium reabsorption, both of which result in hypokalemia and metabolic alkalosis. Third cause of increased renal potassium wasting is hypomagnesemia. As we said earlier, the sodium potassium ATPase in the proximal tubules pumps potassium into the cell and pumps sodium out of the cell. Hypomagnesemia inhibits the action of this pump, and this means that potassium will be on the extracellular side, and it will be leaked into the tubular lumen, and thus promoting potassium loss in the urine, resulting eventually in hypokalemia. Another important channels are ROMC or renal outer medullary potassium channels. These channels are located mainly in the thick ascending limb of Henle and the distal nephron. And the main function of these channels is to secrete potassium. Magnesium normally inhibits these channels and prevents excessive potassium loss. So if we have hypomagnesemia, this will remove this inhibition, leading to increased potassium secretion as the activity of ROMC will increase, and this will increase the urinary loss of potassium, resulting in hypokalemia. And usually hypomagnesemia is a cause of hypokalemia that is refractory to medical treatment. Fourth and the last cause of increased renal potassium wasting is hyperaldosteronism states. Aldosterone works in the distal tubules to reabsorb sodium by upregulating the epithelial sodium channels and excretes potassium and protons. High aldosterone levels can be primary or secondary. Primary hyperaldosteronism, usually here we have an intrinsic disorder in the adrenal gland, and we usually find high aldosterone and low renin levels. While in secondary hyperaldosteronism, here merely the problem will be excess renin secretion, and here we will find high renin and high aldosterone. After we've talked about definition and causes of hypokalemia, we will talk about hyperkalemia definition and causes. Hyperkalemia is defined as a serum potassium concentration greater than 5.5, and severe hyperkalemia can lead to life-threatening cardiac arrhythmias, therefore requires prompt management. Regarding the causes of hyperkalemia, we have two major groups or two major mechanisms, either increase potassium movement out of the cell or decrease shifting into the cell. And the second mechanism is renal retention of potassium. Either low glomerular filtration rates, so deficient potassium filtration, or low aldosterone states, so deficient potassium excretion. This potassium shifting into the cell. Before we discuss this, when we talked about hypokalemia, we established that overstimulation of sodium-potassium ATPase lead to hypokalemia. So on the opposite side, if the sodium-potassium ATPase is inhibited or the activity of the pump is decreased, this will lead to less potassium movement into the cell and less movement of sodium out of the cell, causing high serum potassium levels. So the causes of this are like low insulin states, which we usually see in diabetic patients when they present with DKA or hyperosmolar hyperglycemic states, and also drugs like beta blockers and digoxin, but when digoxin usually in overdose. Mechanism of hyperkalemia is increased potassium movement out of the cell or cell lysis. By this we mean there is a breakdown of certain types of cells like RBCs, muscle cells, or malignant cells, which result in release of potassium into the bloodstream causing hyperkalemia. So, for example, in hemolysis, which lead to increased release of potassium into the bloodstream, along with other features of hemolysis like anemia, high lactate dehydrogenase, and low haptoglobin, while in seizures or in crush injuries, this will cause breakdown of muscle cells and rhabdomyolysis, causing high potassium, high creatine kinase, and high urinary myoglobin. In patients with hematological malignancies who receive recent chemotherapy, these patients can develop tumor lysis syndrome caused by killing of the malignant cells by the chemotherapy. This will lead to high potassium, high LDH, high uric acid, phosphorus, along with low serum calcium levels. The second mechanism of hyperkalemia is renal retention of potassium, and it usually happens in advanced acute kidney injury or chronic kidney disease when the GFR is below 30. Potassium filtration through the glomerulus will be decreased, leading to accumulation of potassium in the bloodstream. In this patient, usually we will find high renal profile with or without decreased urine output. Low aldosterone states, normally renin production will stimulate aldosterone production, and then aldosterone will exert its action on this receptor. So when we say low aldosterone state, we mean that we might have a problem either in renin production or normal renin production with low aldosterone production, or normal renin and aldosterone production, but the problem is in the receptor. So the end result is that this will impair the sodium reabsorption in the distal tubules through the epithelial sodium channels, as well as potassium and hydrogen excretion. And this will lead to hyperkalemia and metabolic acidosis. So the first possibility is either we can have low renin production, therefore low angiotensin and less aldosterone. This case can be due to diabetes or non-steroidal anti-inflammatory drugs. The second cause is decreased aldosterone production, which can be due to angiotensin converting enzyme inhibitors or angiotensin receptor blockers, or in adrenal insufficiency. And the third possibility is blocking the action of aldosterone in the distal tubules, which can be caused by drugs like spironolactone or trimethoprim sulfamucil, which is septrin. And in these patients, we can find low sodium, low blood pressure, hyperkalemia, along with metabolic acidosis. Another possible cause of hyperkalemia is acidosis. Normally, in the collecting ducts of the kidney, we have this pump, which is called hydrogen potassium pump, which moves potassium into the cell and moves hydrogen out of the cell. So in acidosis, the activity of this pump increases, which means more potassium reabsorption into bloodstream and more hydrogen excretion into the urine as a compensatory mechanism, leading to hyperkalemia and also, on the other hand, trying to decrease the degree of metabolic acidosis. Implications of potassium disorders. Hypokalemia increases the excitability of the cardiac myocytes, causing different types of arrhythmias. So the effect of hypokalemia on the cardiac myocytes is that it increases the excitability of the cardiac myocytes. On the other hand, it decreases the excitability of skeletal muscles, smooth muscles, and neurons. And this will lead to weakness and fatigue, paralytic alias, and decreased deep tendon reflexes, with or without paralysis. This slide demonstrates the ECG changes in both hypokalemia and hyperkalemia. The typical ECG changes in hypokalemia, we can find T-wave inversion along with ST segment depression and U wave or prominent U wave. While in hyperkalemia, we can find peaked or hyperacute T wave, flat P wave, PR prolongation, and widening of the QRS complex. So we discussed the various definitions, causes, presentations, and complications of potassium disorders. We are going to go to the practical part, and it is what to do if we are faced with a patient with hyperkalemia. The first step is that we should recheck the potassium level in order to exclude pseudo-hyperkalemia, as if the blood sample was taken while tourniquet is applied, or if the blood sample is hemolyzed, this can cause pseudo-hyperkalemia. So the first step that we should recheck the blood sample, and if we confirm that the patient has hyperkalemia, then the next step is to look for the cause. Looking for the cause means obtaining history in addition to doing lab test. From the history, like history of any drug use or history of seizures, history of crush injury, history of malignancy, receiving chemotherapy, and history of anemia. So, for example, if the patient is using recent beta blockers or digoxin, this can be the cause of his hyperkalemia. If the patient developed any recent seizure or crush injury, rhabdomyolysis can be the cause, and so we should obtain a creatine kinase level. If the patient has a malignancy and recently received chemotherapy, we should think of tumor lysis syndrome and obtain LDH, uric acid, and phosphorus level. And if the patient has clinical features of anemia or history of anemia, we should obtain a level of LDH, haptoglobin, and blood smear to look for evidence of hemolysis. Then we should obtain kidney function or a GFR. If the GFR is low, this means that acute kidney injury or chronic kidney disease is the cause of hyperkalemia. And if the GFR is normal, we should think of hypoaldosteronism and obtain renin and aldosterone levels. We can find either low renin and low aldosterone. This usually we see it with non-steroidals or in diabetic patients. If we find high renin and low aldosterone, we should think of adrenal insufficiency or use of ACE or ARBs. And if we find high renin and high aldosterone, we should think that the problem is in blocking the mineralocorticoid receptors by either spironolactone or septrin. Developing the diagnostic approach of hypokalemia. So if we are faced with a patient with hypokalemia, first we should rule out the transcellular shifting of potassium by asking about any recent use of insulin, any recent use of salbutamol or albuterol, and if alkalosis is present. So the first step, we should obtain a urinary potassium. we can find either high urinary potassium or low urine potassium. If we find low urine potassium, this means the cause of hypokalemia is GI loss of potassium. And the next step will be to obtain arterial blood gas to know is the loss from the upper GI tract or from the lower GI tract. If we find metabolic alkalosis in the ABG, means that the cause is either vomiting or NGT suction. And if we find metabolic acidosis, means that the cause of hypokalemia is diarrhea. So, in case we found that the urinary potassium is increased, this means that there is renal loss of potassium. The next step will be to obtain a blood pressure. If we found high blood pressure, the next step will be to do renin and aldosterone levels. If we find high renin, low renin, and high aldosterone, we should think of primary hyperaldosteronism. If we find high renin and high aldosterone, we should think of secondary hyperaldosteronism. But if we find both low renin and low aldosterone, the cause can be apparent corticoid excess, but we will not discuss this in this topic. If we find the blood pressure is low, the next step will be to obtain magnesium level and arterial blood gas. If the magnesium is low, this means that the cause of hypokalemia is hypomagnesemia. If we found metabolic alkalosis, we should think of diuretics as the cause of hypokalemia. And if we found metabolic acidosis, we should think of renal tubular acidosis, either type 1 or type 2. Regarding the management of hypokalemia, the management, we can give potassium replacement, either oral replacement or IV replacement. So when we use oral potassium is when the serum potassium is more than 3 and no ECG changes. Here we can replace the hypokalemia by giving oral potassium in the form of potassium chloride or potassium bicarbonate. So if the potassium is serum potassium is less than 3 and or there is ECG changes, here we need to give IV potassium, and usually we give potassium chloride. So how much IV potassium we are going to give according to the degree of deficiency, and usually a 10 milliequivalent of potassium increase the potassium by 0.1 milliequivalent in the serum potassium. So, for example, if the patient serum potassium is 2.9 and we want to give IV potassium, our target is to reach 3.5. This means that we will need 60 milliequivalent of potassium to increase his serum potassium from 2.9 to 3.5. The next thing that we can do is we can give magnesium if the patient has hypokalemia secondary to hypomagnesemia, refractory hypokalemia secondary to hypomagnesemia. As we discussed that hypomagnesemia will promote potassium excretion by inhibiting the sodium potassium ATPase in the proximal tubules and by its effect on the ROM channels in the distal tubules. So if we replace magnesium, we will prevent renal loss of potassium. So if we have hyperaldosteronism and hypokalemia, here we can use aldosterone antagonists like spironolactone and eplerenone in order to treat hyperkalemia. As we discussed that aldosterone increases sodium reabsorption and promote potassium excretion. So if we use aldosterone antagonist to antagonize the action of aldosterone, we will decrease the renal potassium loss. But this will be of benefit only if we have a patient with hyperaldosteronism. So when we are replacing potassium, if we have serum potassium of more than 3, we can use oral either potassium chloride or potassium bicarbonate. According if the patient has metabolic alkalosis, we can use potassium chloride. If the patient has metabolic acidosis, we can use potassium bicarbonate. If the patient serum potassium is less than 3 or the patient has ECG changes, we should use IV potassium. And when giving IV potassium, we should put in mind that if we are going to give potassium through a peripheral IV line, we should not exceed 10 milliequivalent per liter per hour, as potassium when given in a peripheral IV can cause thrombophlebitis or venous sclerosis. And if we need to give more than 10 milliequivalent per liter per hour, we can give it through a central venous line up to 20 milliequivalent per liter per hour. So if we give the potassium either IV or oral, and then recheck the potassium and find that the potassium is still low, the next step that we should check the serum magnesium. If the serum magnesium is low, then we should replace the magnesium. And if there is normal magnesium, then we should check the aldosterone. If the aldosterone is high, then we can use aldosterone antagonists. Regarding the management of hyperkalemia, usually we start management of hyperkalemia when the serum potassium level is more than 6 and or there is ECG changes. The first step is to protect the heart by giving calcium gluconate, and the dose is usually 10% over 10 minutes. And the next step is to start shifting potassium from the extracellular space to the intracellular space, either by using insulin or inhaled albuterol. Insulin, we give 10 units of regular insulin plus dextrose 50%, 50 ml. But before that, we need to make sure of the blood glucose of the patient, as if the patient is diabetic and he has high blood sugar, we don't need to give dextrose. We can only give insulin and monitor his blood sugar. The use of beta-2 agonists is we usually need high dose of beta-2 agonists compared to the dose we use in asthma and obstructive lung disease in general. Here we give around 10 to 20 milligram. We can also use IV bicarbonate, but provided that the patient has acidosis. So after protecting the heart and shifting potassium, the next step will be to remove potassium from the body, either in the urine or in the GI tract. So if the patient has serum potassium of more than 6 and ECG changes plus functioning kidneys, and he is able to produce urine, we can use loop diuretics like furosemide, torsemide, and bumetanide to excrete potassium through the kidneys. And if the patient has non-functioning kidneys, then we can use potassium binding resins like sodium polystyrene sulfonate, sodium zirconium, and pyramidine. These resins excrete potassium through the GI tract. This is an example for potassium binding resins. Usually it contains sodium and calcium, which are absorbed in the GI tract in exchange of potassium, which bind to the resin and then excreted in the stool. The potassium binding resins usually are used in mild hyperkalemia, and they usually take long time to exert their action. And usually we use them in an uric patient, as diuretics are more effective in removing potassium compared to the resins. So usually we use them in mild or chronic hyperkalemia. And the next option, if the patient has refractory hyperkalemia that did not respond to the above treatment, the next step is to go for hemodialysis and to remove potassium from the circulation, and for that we will actually need an access like central venous catheter or AV graft or AV fistula. Special cases where we have hyperkalemia secondary to adrenal insufficiency, we can manage hyperkalemia by giving aldosterone agonists like fludrocortisone, which will prevent the renal retention of potassium, as we know that aldosterone is important for potassium excretion. So if we have aldosterone levels that are low and resulting in hyperkalemia, here the management of hyperkalemia will be by replacing the aldosterone in order to promote potassium excretion and to manage the hyperkalemia. So to summarize the management of hyperkalemia, if we have a serum potassium more than 6 and no ECG changes, The next step will be to excrete potassium from the body by using potassium binding resins in mild cases of hyperkalemia, or if the patient is anuric, or we can use loop diuretics in moderate to severe cases and the patient is able to make urine. And if the patient has serum potassium more than 6 and ECG changes, then we are going to stabilize the cardiac membrane using calcium gluconate, and then we are going to shift potassium into the intracellular space by administering insulin plus minus dextrose 50% and albuterol and bicarbonate if the patient is acidotic. After that, if the patient responded to treatment, then we are going to prevent recurrent hyperkalemia. If the patient did not respond to the above management, and the patient has refractory hyperkalemia or severe acute kidney injury or end-stage renal disease, we are going to remove potassium from the body by hemodialysis. If the patient responded to treatment, then we are going to prevent recurrent hyperkalemia by treating the cause, like discontinuing the culprit medications like nonsteroidals, ACE inhibitors, ARBs, potassium-sparing diuretics, or septrin. And that would be all about potassium disorders. And hopefully this session has deepened your understanding and provided practical insights that you can apply in your clinical practice. Thank you and all the best.